Most patients, they may or may not know that they have psoriasis. So a lot of patients have a rash. Sometimes the rash is new, it just showed up. Sometimes they've had it for a very long time and they've just decided to get it treated. But typically they have complaints of flaking skin, pain, itching, sometimes the rash spreading other places, and that could be the triggering factor as to why they come in for treatment. So psoriasis is an autoimmune condition, which means the immune system is working too hard. It's producing too many skin cells, and those skin cells start to build up and cause the rash. It's also a chronic condition, which means unfortunately there is no cure for psoriasis. It is something we have to manage, which means we start treatment and we usually have to continue those treatments as needed throughout life. Outside of the rash, you can also get inflammation throughout the body, since psoriasis is just not a condition of the skin alone. It can cause inflammation in our joints, known as psoriatic arthritis. Sometimes it can cause nail psoriasis, which can cause pain in our nails, can cause discoloration, some lifting of the nails or breaking. We can also get inflammation in our gut from psoriasis, and then sometimes we'll see cardiovascular disease. So that could be things like metabolic syndrome, where we see obesity, we see high blood pressure, high cholesterol, diabetes, and even depression. All of those things can go along with psoriasis. So psoriasis can be diagnosed at any age, but most commonly we see what's called a bimodal peak, which means that the first onset of psoriasis is typically around the age of about 20 to 40. That's where most patients get diagnosed. And then we see a second or late onset peak, which is usually around the age of about 40 to 60. Many patients see the rash first. Yes, you can, it's rare, but you can have psoriatic arthritis without having skin psoriasis. So it's not common, but it's possible. Most patients, their initial complaint when they're coming in for a visit is the rash, especially in dermatology. Sometimes if they just have the nail psoriasis, they'll come in thinking it might be fungus, and sometimes we do need to actually do a little clipping of the nail to see if there is fungus there. So the most common type of psoriasis is what we call plaque psoriasis. So that can show up anywhere on the body. The most common place we see that is the scalp. We often will see it on the elbows, the knees, the gluteal cleft, which is kind of at your lower back, top of the buttock area. So it's very common there as well. But like I said, can show up anywhere. That will typically be a rash that has a very sharp edge, which means you can tell where it starts and where it stops. It will be red, inflamed, typically raised up, and maybe a little bit scaly. So that's our most common type, plaque psoriasis. There is a type of psoriasis called guttate psoriasis. We most commonly see that in children, but can be seen in any age group. That oftentimes, about 50% of the time, will show up after some sort of infection, whether that's like an upper respiratory viral infection or a strep infection. That will look like little tiny spots of psoriasis kind of all over the place. Sometimes you can have that and it will go away. It won't necessarily be chronic. Sometimes it can turn into plaque psoriasis with time. There's a type of psoriasis called inverse psoriasis. Inverse means it's in the body fold. So we see that behind the ears, armpits, under the breast, under the abdominal fold, in the groin. That is going to be less raised up, less scaly. Typically will be kind of red and shiny, almost raw. Sometimes causes little cracks in the skin, which can be quite painful. There are some other types of psoriasis, which are a little bit less common. There's one called erythrodermic psoriasis. That is when basically your whole body, all the skin on the body starts to turn red. It can be quite painful. It can cause fevers, just overall illness. That is usually more severe. And then there's some types of pustular psoriasis. So there's one type of pustular psoriasis where you get it on the palms of the hands and the soles of the feet. So that looks like little whiteheads forming on the skin. Sometimes you can have little brownish red spots under the skin too of bleeding. And the skin often will peel off in those areas. You can also get generalized pustular psoriasis, which is a little bit more rare, but you get those teeny tiny little whiteheads on a lot of surface areas of the body. Same thing, you'll see some peeling skin too. A lot of patients will come in and they'll say dermatitis, which is kind of a general term that means inflammation of the skin. They say, oh, I've been diagnosed with dermatitis. Dermatitis isn't very specific, so sometimes patients can truly have eczema or psoriasis, which is kind of like a type of dermatitis. So as far as eczema or dry skin goes, it typically doesn't have that clear, sharp border like psoriasis does. It's not usually as raised up. It can still be scaly, but sometimes no, it can be very challenging to tell the difference between the two. So in which case, if we're ever doing treatments and we can't tell the difference and we really need to know the difference to know what next step we're going to take in treatment, we can do a skin biopsy where we numb the skin, we take a little piece of the skin, we send it out to our dermatopathologist who look at the skin under the microscope, and they can let us know, yes, this is psoriasis, yes, this is eczema, or some completely other rash that we need to get treated. So most common trigger to bring out psoriasis or to cause a flare-up is typically stress. Stress can look like a lot of different things. It can look like emotional stress, so maybe you're stressed out at work, maybe you had the loss of a loved one, maybe you're undergoing a move, that sort of thing. But it can also be stress on the body. So like you underwent a surgery that caused stress, you had a fever or some sort of illness. All those things stress out the body and can cause psoriasis to flare too. So that's a common one that most patients know, they understand. Wintertime is also a common flare for a lot of patients. The skin's dry, we have cold, dry air, we're not getting a lot of sunlight, and that can flare psoriasis and eczema as well. Telling a patient to decrease their stress levels is something like, it's a little bit laughable. It's a lot easier said than done, but you can start with like the basics. So focusing on getting a good night of sleep, focusing on eating healthy food, focusing on, decreasing screen time when you can. Going for short walks is a good way to start, moving your body. All of those things can help to decrease stress levels and help to settle inflammation in the body. So starting there at the basics can be helpful, but yes, I understand it's easier said than done. Start small, because a lot of times if you try to start big, it's just too overwhelming and you give up. So like starting small, and then once you start to feel better, you can, progress that. Talking about triggers, we talked about stress in winter time, cigarette smoke, alcohol, certain medications can actually trigger psoriasis. A very common one is a beta blocker. So that's a medicine taken for either heart rate or high blood pressure, like atenolol or metoprolol. A lot of patients are on that, so that can trigger psoriasis. We talked a little bit about how infections can trigger psoriasis. Trauma, so if you have a sunburn or a rash or you kind of get a scratch on your skin, that can trigger psoriasis as well. I think it's important for them to know that yes, there is inflammation internally as well. So sometimes when we're just treating with topicals, creams, sometimes that's appropriate, but it's not going to treat your joint pain. And when you have psoriatic arthritis and the psoriasis starts to damage the joints, that's not reversible, at least not at this time. We can stop the progression, we can stop the damage to the joints, but we can't repair them once it's occurred. So sometimes we do need medications that work from the inside out to treat this condition, to protect our joints, to protect our cardiovascular system, to decrease the risk of things like blood clots and heart attacks and strokes, because we see psoriasis causing inflammation in other areas of the body. Sometimes with the joint pain, they're like, oh, well, it could just, be wear and tear, or what we call osteoarthritis. But sometimes there can be signs that it's more psoriatic in nature, especially like when we see things like the swelling of fingers and toes. That's very classic for psoriatic arthritis. So a lot of times it depends on what the patient is interested in. I like to make that decision together so that they're comfortable with the treatment plan. But many times we're deciding what the best treatment plan is based upon how much of the body is covered or what area. So for example, if you have your hands and feet covered in psoriasis, even though that's not a large portion of your body, that's a very important portion of your body. So that, even though it's a small area, is considered more severe. There have been patients who have come in and they're like, I can't shake hands with people at work, or I have trouble doing my job because it's hard for me to be on my feet all day with my psoriasis. So if that's the case, it's inhibiting, your activities of daily living, your ability to do your job. I want to be more aggressive with treatment. So we might talk about oral therapies or what we call biologic injectable therapies, opposed to topicals right away. If somebody has one small patch that's itchy, a topical may be appropriate, but typically if we are seeing things like joint pain, I'm having the conversation about either an oral medicine or an injectable biologic medication that also treats psoriatic arthritis. Joint pain can look like swelling of the fingers. It can look like redness or tenderness in the fingers, but oftentimes it will be joint pain that does not go away within like 30 minutes of waking up. A lot of times we see it in our small joints, like in our hands and our feet, but we can see it in our spine or any joint in the body. And a lot of times it will be like one-sided, whereas other types of arthritis might impact both sides of the body. The first thing I like to mention is there are a lot of different treatment options for psoriasis right now, so I don't want patients to get frustrated or discouraged. We want to try to do whatever treatment they need and trial and fail whatever they need in order to get them better. But a lot of patients will say things like, I'm going on vacation and I'm not comfortable in a swimsuit, or I haven't worn shorts all summer because I'm embarrassed about my psoriasis, or I have a wedding coming up. So we want to get their skin clear so that they can feel comfortable in their skin. A lot of people underestimate the emotional aspect of not feeling comfortable in your own skin. And we can look at the itching causing patients to stay up at nighttime. So we're looking at decreased quality of sleep, which decreases your quality of life as well. So getting the psoriasis under control so that you can get a good night's sleep. Psoriasis often impacts the scalp. So people can get embarrassed about scratching their scalp, the flaking that you'll see on clothing. That's usually something that is very emotional for patients. I had a patient recently who was in tears because she felt so embarrassed at the hair salon about what was going on her scalp, and her hairdresser, she said, was talking about it loudly, and she felt like people were staring at her. And patients get concerned that people think this is contagious or a hygiene issue, which it's not contagious or a hygiene issue. There are topical therapies, so those are creams that get applied once or twice a day depending on the cream. There are some topical steroids, everyone knows about those. We do use some creams that are basically kind of like vitamin D. That helps to kind of slough off all that extra skin scaling that builds up. And then there are some newer creams like Vitama and Zoryve, which are once a day and really great options since they're not steroidals, that you can use for longer than 2 weeks, because psoriasis definitely can last longer than 2 weeks. The other medicines would be oral medications. So there are some newer oral medications like Otezla. There is one called Sotyktu. There is one that recently came out like in a month or so ago called Icotide. And then there are some older medications that have been used that are oral, like methotrexate or cyclosporin, which are not my favorite at this point in time, but there's a place for them sometimes. And then the biologics are injections, and those are typically given at home. They're kind of like usually like in an EpiPen form, so it's like an auto injector. You don't see the needle, and they're done between every 4 weeks to every 12 weeks, depending on the medicine, and those work very nicely. Typically, we're looking at what body surface areas are impacted. So hands, feet, scalp, those can be a little bit more stubborn, as well as nails. Those are pretty stubborn. So if we see those areas impacted, we're typically a little bit more aggressive. If they're smaller body surface areas, we may start with the topical, and then if the topicals are not working, kind of move up to those oral or injectable options. Sometimes I'll have patients come in and they're just covered, and we want to go straight to that injectable medication, because putting a cream all over the body twice a day is really not too feasible, and we want to get that quality of life improved. When you have more severe psoriasis on the skin, that could mean there's more inflammation going on in the body too, which we want to treat and protect against. Especially with the newer medicines we're seeing, we've come such a far way in our psoriasis treatments that I want most of my patients to be either clear or almost clear with their treatment. So when you have inflammation going on throughout your body or joint pain, sometimes it can be hard or challenging to make lifestyle changes. So a lot of times I say lifestyle changes partnered with the treatment plan. Hopefully this treatment plan starts, it gets you feeling better, and then those lifestyle changes become a little bit easier to make. As far as things that we can do, smoking cessation can be helpful, which is a challenging thing to do, but quitting smoking is helpful because we know that that can flare psoriasis. It can also trigger psoriasis. The smoke exposure, decreasing alcohol in our diet. Alcohol is inflammatory, so psoriasis is inflammatory. We want to decrease anything that causes inflammation in the body. So consistency with treatment plans, healthy lifestyle. So we talked a little bit about a good diet, exercising, all of those things can be helpful, as well as weight loss sometimes. We don't exactly know if the obesity comes before the psoriasis or as a result of the psoriasis. We've seen it both ways. But what we do know is when patients start to lose weight, they cut down on smoking, those sorts of things, their psoriasis disease state typically improves as well. So those partnered with the treatment plans. I had a patient who had some pretty localized psoriasis, so it was just really in one area of the body, and they had tried a couple different topical treatments. They weren't really interested in anything more than topicals, and the psoriasis would get a little bit better, or it might go away, but then it just kept coming back. It kept reflaring. So they made some dietary changes where they cut out a lot of inflammatory foods from their diet, some foods that they knew like, oh, every time I eat this, I get a little bit of a stomach ache. And just by taking that out and continuing with the topicals, they were able to get the psoriasis under control and then stop the topicals and basically not reflare as soon as they stopped the medicine, which is great. That was from diet alone, like no other things like weight loss or smoking cessation, just looking at a couple things that irritated their gut, since the gut and the skin do work closely together. I wish that more patients knew that there are so many great treatment options so that they don't get discouraged. Some patients have been living with this disease their whole life, and maybe, 20 years ago we didn't have all the great treatment options that we do now, so they kind of just gave up on it. And I wish that they knew how many great, safe treatment options we have that can get them pretty clear. We used to look at, in clinical studies, trying to get patients 50 or 75% clear. Now we're looking at more getting them 90% clear. So that bar has certainly increased of what we want to achieve, and I think that patients could be very happy with the results that they could get. Another thing is psoriasis is common. 7.5 million Americans have psoriasis. So it's not something to be embarrassed about. It is something that you should, seek treatment for and get it taken care of.